Thank you. Thank you very much. It is really a great pleasure for me to be here in such a lovely place, so close to my home, and have this opportunity to talk with you about one of my favorite topics, the adhesive restorative dentistry. So I really want to thank all the board for the kind invitation. Let me quickly introduce myself. Let me quickly introduce myself. I'm from Trieste, nearby Trieste. I am an active member of the Italian Academy of Conservative Dentistry, of the Italian Academy of Aesthetic Dentistry, and of the Italian Society of Conservative Dentistry. I want to leave you all my contacts, my Instagram account, because I really think that it is an easy way to keep in touch, and also my email address. So if you will have any further questions, or you will need some full article, the full text of someone of the articles that you will see later on during the presentation, you just text me and I will answer to you as soon as I can.
Thank you very much.
Now, as I said, I graduated in Trieste in 2010, and since the day of my graduation, all my efforts in terms of learning and training were focused on restorative dentistry, especially on conservative dentistry. And nowadays, it is with this kind of background that I try to approach almost every clinical situation in my daily practice. And nowadays, I really think that when we talk about restorative dentistry, it is almost impossible to draw a line between conservative and prosthetic. Why? Because nowadays we are able to solve with a direct approach even very complex situations like wide cavity, very extensive cavity that just a few years ago can only be treated by a prosthetic approach. On the other hand, in prosthetic, we are using more and more materials like glass ceramics, for instance, that are really good and aesthetic materials and that work best when they're bonded onto the dental substrates. Okay, with the same adhesive techniques and materials that represent the fundamentals of all the conservative dentistry since 1991 till today. And so it is in this kind of scenario where we don't need to hide anything in the sulcus because we don't have any more metal margin to hide in the sulcus, and where we don't need for retention from the abutments because we are going to glue directly the restoration onto the tooth surface. Well, the position of the margin of our restoration can only be determined by the extension of the cavity, by the lack of structure of the tooth. Basically, every time we start a restorative treatment, no matter if with a direct approach or with a prosthetic approach, what we are doing is to open a cavity, to remove all the previous restoration, to clean the cavity from all the infected and softened dentin. And at this point, we need to perform a 3D biomechanical evaluation of the remaining tooth structure. We have to measure the height and the thickness of the remaining cusp, because the higher and the thinner are the cusp, the more will they bend and break under the occlusal load. And so at the end, we basically can find ourselves in two types of situation. The first one, the easy one, is when all the remaining structure is strong enough to support the occlusal load. And so our cavity preparation is completed after we have completed the cleaning of the cavity. And we can immediately proceed with the restorative phases. Or in the other situation, the remaining tooth structure, the remaining cusps are weakened and are going to fail under the occlusal load. So in this situation, we need to enlarge our cavity preparation. We need to extend our cavity preparation, reducing the weakened cusp and including that or those cusps into the final restoration. But now let's see some clinical examples for better explain what I mean. Starting with this woman who comes to our office with a lot of old composite restoration. Not the best one I ever see, but to be honest, not even the worst. But as soon as we zoom in, as we start give a closer look at the situation, we can start see some issues, some chipping, some proximal contact that doesn't work, leading to some food infection, some primary and secondary decays, as you can see also from the x-rays. And so according with the patient, we decide to replace them all. So we split the treatment into 4 sessions, 1 session per quadrant. And now let's see quickly the treatment of just the Quadrant number 2, we start the treatment by isolating all the field. We place the clamps on the more distal tooth. We place all the teeth under the rubber dam until at least 2.2. Then we remove the all composite restoration. We expose the primary decays. We clean the cavity from all the softening tissue. And this time, all the remaining cusps are strong enough to support the occlusal load. I mean, we can hypothetically let the patient go home and we can let her chew whatever she wants without putting any temporary feeding, any composite or stuff like that. And we can be quite sure that from the mechanical point of view, nothing's going to happen, no cusp will break down under the occlusal load. And so in this situation, once we complete the cleaning of the cavity, we simply have to refine the margin with some fine grit diamond burrs, some strips, some Evine pieces, whatever you like, and then we can immediately proceed with the restorative phases. So we place the matrices, we stabilize them with a wedge, we apply the adhesive system, and then we start restoring the marginal ridges. First, according to the centripetal build-up of Nils and Bicciaccio, we transform the class 2 into class 1, then using a bulk-field flowable composite, we level up the bottom of the cavity, leaving 2.5 millimeters of occlusal space to complete the treatment with a single shade medium translucency composite with which we model the occlusal anatomy of the restoration. And if we give the right proportion between the cusps, if we place the pits and the fissure in the right position, where we can obtain some good result, both in terms of aesthetic, in function. We probably don't need for a lot of occlusal adjustment. Here's the result immediately after the treatment, and here is 2 years, and here is 2 years follow-up. Of course, all these quadrants were quite easy situation because all the cusps could be maintained because all the margins were supragingival, so it was quite easy to isolate them, to manage with the matrices. But the ugly truth is that in our daily practice, we usually have to face and have to deal with more complicated situations, just like this 2.6. For instance, in fact, once we remove the all composite restoration, once we complete the cleaning of the cavity, well, that remain mesiolingual cusp obviously cannot stand under the occlusal load, is going to fail also under the polymerization shrinkage stress of the first layer of composite that we are going to liqueur directly in the mouth. So we need to enlarge, we need to extend our cavity preparation, reducing that cusp and prepare the tooth for receiving a partial cuspal coverage restoration. Now, at this point, there are two paths in front of us that we can walk by. We can quickly build up the tooth with some composite, refine the preparation, take an impression, and complete the treatment during a second appointment or some hours later if you were going with a chairside approach by luting an indirect restoration, or we can also proceed with a direct approach, using a stamp technique to stamp the missing cusp, transforming the complex situation into an MOD cavity with a sort of comfort zone for the one like me that every day do direct restoration. And as a common class 2 restoration, I'm going to treat this tooth. So I place the matrices, I restore the marginal ridges first, transforming class 2 into class 1. Once again, I level up the bottom of the cavity with some bulk-field flowable composite, and at the end, I complete the treatment, restoring and modeling the occlusal anatomy with a single shade medium translucency composite. Once again, if we have been neat and tidy during the stamp phases, if we don't mess too much with the excesses, if we place the pits and the fissure in the right place, we give the right proportion between the cusps, we probably don't need for a lot of occlusal adjustment. We can achieve a good aesthetic result, both in terms of aesthetic function, not just at baseline, but even at the medium long-term period, because this is a 5 years follow-up. The restoration is still working pretty good. This restoration is part of a multi-center prospective study that we're going to publish soon Together, we have Dr. Mario Alessio Allegri, Luca Grometto, and other colleagues about these topics. Now we have more than 7 years follow-up of our restoration, and we can definitely say that this technique of this direct technique for caspal coverage restoration can be considered an effective and a valid treatment option compared to the indirect solution. Of course, this doesn't mean that it is an easy technique, because for sure could be quite difficult in some cases to manage the occlusal and proximal anatomy in very large cavity when there are only few points of references. Moreover, we have to licure very big amount of composite directly in the mouth. This means that we have to deal with the polymerization shrinkage stress. And this means that we have to layer a lot. And the more we layer, the higher the risk to include bubbles, debris, or make some mistakes like incompleted licuring of the composite. And so for this and other issues in our daily practice, we can be more predictable in this kind of situation with an indirect approach, because first of all, the lab, not us, has to deal with the anatomy. Second, we don't have to care about the polymerization shrinkage stress, because the only composite we are going to licure directly in the mouth will be the very thin layer of resin cement that we are going to use during the lutein phases. And last but not least, we can select different type of materials with better mechanical properties, like glass ceramics, for instance, or resin matrix CAD-CAM block, but also the same CAD-CAM composite, which is on another level in terms of biomechanical properties compared to the layer one. Now, when we talk about indirect approach, this doesn't mean always full crown. We should prefer partial adhesive restoration every time it's possible to enjoy the benefits of this type of technique. Because, for example, first of all, we can really speed up all the process, because the margin of partial adhesive restoration have to be supragingival by definition, because we need to record them during the impression, we need to isolate and manage them during the lutein phases. And if the margin is supragingival, this means that there are no interaction between the restoration and the soft tissue. This means that we doesn't have to condition the soft tissue. We don't have to prepare the gums for receiving the final restoration when we stay partial and adhesive. So we can completely skip the temporary phases and we can speed up all the process. But the main advantage is that, of course, we can be less invasive to the natural tooth structure if we prepare partial compared to full crowns. And from the biomechanical point of view, there's no reason at all to prepare full crowns. In this study that we published with the University of Trieste in 2000. I think 18, we compared several aspects of teeth restored by a lithium disilicate overlay compared to lithium disilicate full crown. And at the end, there were no differences in terms of fracture resistance between the two groups. In 2019, a couple of years later, in 2021, Federico Ferraris and his research group take cue from this article and published another paper on this about this topic, in which they increase the number of the group, they increase the number of the samples for each group, they introduce also a control group made of natural sound teeth. And at the end, not only full crowns did not perform better in terms of fracture resistance, but teeth restored with lithium disilicate overlay with a full circumferential bed has shown the highest fracture resistance compared to all the other groups, higher than the natural sound tooth. But now let's go ahead and let's see a clinical case to go deep into the details of the workflow and of the clinical protocols that we need to apply in our daily practice to be predictable in every clinical situation. So let's start seeing this quadrant number 3. I think that we all can say that 3.6 requires a full cast part coverage restoration, because there is already a very big all composite restoration that includes the mesiolingual cusp. The purplish color of the buccal cusp suggests that there is a lot of decay right underneath. The distal margin is cracked. So we can really suppose that we are going to restore the 3.6 with a full cast part coverage restoration. And in fact, as soon as we start the treatment, we once again isolate all the field, placing the clamps on the more distal tooth. We remove the all composite restoration, and as we have presumed, there is a lot of decay right under the buccal cusp. So we remove also the all composite restoration on 3.7. We complete the cleaning of the cavity, and once we have completed the cleaning of the cavity, the remaining cusps are weakened and are going to fail under occlusal load. So we need to enlarge our cavity preparation. We need to reduce the weakened cusp and prepare the tooth for a full cast part coverage restoration. Now, once the cavity on 3.6 is open, I can directly see an initial decay on the proximal surface on 3.7 that I decide to treat with minimal invasive cavity preparation, preserving the upstanding marginal ridge. So once all the cavity are completed and prepared, we can move on with the adhesive procedure. And every time I find myself so close to the pulp chamber, I prefer to avoid directly etching the dentin. So I select a self-etch approach. So I just put the etching on the enamel, and then I use a universal adhesive in a self-etch mode onto the dentin. I like the adhesive for at least 60 seconds to increase the degrees of conversion, to increase the mechanical properties of the hybrid layer, and especially to reduce the semi-permeability of the hybrid layer. Then I cover and protect the brand new hybrid layer with a very thin layer of flowable composite in order to seal all the exposed dentin and to complete the immediate dentin sealing procedure. Once done, I start with the restorative phases, starting restoring obviously the cavity on the proximal surface of 3.7 with a medium translucency composite, and then I start layer at the same time the build up on 3.6 and the direct restoration on 3.7. At this point, we simply have to refine the preparation on 3.6. And partial posterior adhesive restoration are not something brand new. They come from the traditional prosthetic, but compared to the Schillenburg 3/4 preparation, new adhesive posterior preparation simply have rounded and more smooth geometry of the whole preparation. We have rounded angles. We avoid any micro retention elements because of the brittle behavior of the adhesive materials that simply don't mix with any friction. We have a rounded geometry also to facilitate the flow of the resin semen that we are going to use and to maximize the adhesive properties of the tooth surface and on the preparation. Now, once we have complete the preparation, we simply have to take an impression or an intraoral scan. We said before that all the margin have to be supragingival. This means that we probably don't have any troubles in recording the margin, both with a polyvinyl siloxane and with an intraoral scan. So we take an impression. I like the most the traditional way, so I still keep taking impression with polyvinyl siloxane. And then I send it to the lab, and we can ask to the lab to make a restoration made of one of our favorite materials. Now, literature doesn't help us a lot in choosing between ceramic and composite because gaps exist in the clinical evidence for the justification of the composite compared with ceramic. But what we know is that for sure ceramic is the main treatment option in highly damaged teeth because it's stiffness. And every time we bond with the proper adhesive procedure, a full cuspal coverage restoration, ceramic full cuspal coverage restoration onto the tooth, we can share the stiffness with a tooth substrate, and we can stabilize the cusp. We can stabilize the cusp together. So I ask for a lithium disilicate overlay. As soon as I get the overlay from the lab, the first things that I do is to try it on the preparation without the rubber dam to check and to set the proximal contacts without the rubber dam, because we know from the literature that the rubber dam may affect the perception of the proximal contact strength. So I set the contact points without the rubber dam, then I place the rubber dam, I try again the overlay into the preparation, but this time, if the contact points are too strong, I'm not allowed to touch the proximal surface anymore with a rubber or with other burrs. We have to work with other tools. We have some wooden wedges or with other orthodontic tools to force the contact points. Now, once we are sure that the restoration fit precisely onto the preparation, we can move on with the luting phases. So we treat the tooth surface by sandblasting the preparation with alumina dioxide, and then I apply a total etch adhesive system. Regarding the restoration, we treat the entire surface according to the material. In this case, we have lithium disilicate, so we etch the entire surface with fluorhydric acid 5% for at least 20 seconds before cleaning the surface from the crystalline debris with an ultrasonic bath. And if you want, also with some orthophosphoric acid before the sterilization. And then I add a drop of universal adhesive because it's full of MDPs. And at the end, we can use both the preheated composite restorative composite or high filled flow composite as luting cement for glue for bond the restoration onto our preparation. So we place the luting cement onto the entire surface, then we place the restoration, we see the restoration in place, and while we are keeping in place with a finger, with a tool, with whatever you want, we remove the excesses, and then we light cure at least 1 minute per surface, and then we refine, we polish the margin, and so we can gain a good aesthetic result, a good blending of the restoration onto the tooth, a good stability of the occlusion, and a good result even at the medium term follow-up. Now, let's leave the posterior teeth behind. Let's move forward. And every time we move from the posterior to the anterior area, it is a completely different story, because the main reason why we need to restore or to treat an anterior tooth is usually the aesthetic, is the aesthetic improvement of the patient's smile. Moreover, all our previous argument about cavity configuration, about 3D biomechanical evaluation of the remain tooth structure simply don't matter now, because in the anterior area, all the remain tooth structure, all the remain enamel, is it well supported or not, is extremely useful during the restorative phases, whatever direct or indirect restoration or indirect approach. And nowadays, there are more ways than ever to restore, to change, to improve a smile, to create new, beautiful smile. And sometimes deciding which technique best suits that specific clinical situation can be a very complex task. But I think that for everything but love, also in dentistry, the right choice is always based on weighing the pros and the cons of the various treatment options. What we have to do is to strike a balance between the need of being as minimal invasive as possible on one side and to achieve the final aesthetic goal. And to do this, for a good aesthetic result, we need to reach both a good shape and color integration of our restoration. But now let's see some clinical examples so that I can maybe better explain what I have in mind. Let's start with this case. This guy comes to our office after he fell off during a bike race and broke 1.2 and 1.1. There are two of the most important teeth in a smile. I really think that this is a complex situation, not just because there are a lot of internal features in those incisal thirds that we need to mimic with our restoration, but also because if we have a look at the parallel side, we can see that the margin of the fracture of 1.2 is deeply below the gingival margin. So now, what are the available options? What can we do for him? I've heard a lot of suggestions. I know that some colleagues would have performed maybe an endodontic treatment, maybe a surgical crown lengthening, then place a full crowns. And I know that this way could work, but in my opinion, it's not so predictable, it's not so easy, it's not so quick. And for sure, it's not the less invasive way. So according to my academic background, I really believe that despite the complexity of the situation, the most effective approach in a case like this is the direct approach. Why? Because in just one appointment, we can easily open a flap, isolate the margin with a rubber dam. At this point, we can apply the adhesive system and freehand directly restore with some composite the missing cingulum. Once done, we remove the rubber dam, and with an open flap, we can finish and polish properly the composite surface, paying attention to obtain an homogeneous, tough surface without any voids, any steps, well-polished surface. Once done, just 2 stitches on the papillas, and then we are ready to place immediately again the rubber dam, isolating all the field and creating the ideal condition for the direct technique. Because now we can easily sandblast the tooth surface, then we can use a silicone guide to stamp the palatal shell with a translucent enamel shade of composite. At this stage, I usually do a pre-finish step with a paper disc in order to gain the correct shape as soon as possible in order to avoid carrying around mistakes during the following steps. Once I have the right shape, I go on and I complete the box of my restoration using some sectional matrices that I place vertically and slightly into the sulcus. And once the box of my restoration is completed, I can take my time pretending to be an artist, playing with different shade, different opacity in order to copy and mimic the internal features of the apical third. So maybe I put some stains in it, and then I cover it all with the last buccal layer of composite. Now, for the buccal layer of composite, we can use a translucent enamel. We can use a medium translucent body shade composite, or we can use them both. We can place the translucent enamel onto the incisal first to enhance the internal features underneath. We can place the medium translucency body shade composite onto the margin for a better blending of the restoration. Then with the brush, we can spread them together, and we have to light cure them at the same time, because this is the only way to get an homogeneous surface and polishable surface. So that's what I do. That's what I did. And once I complete the layering phases, I just spend some more time in taking care of the shape, taking care of the transition angle in order to achieve a good integration of our restoration, not only a good color integration, but also a good shape integration with the neighboring teeth. This is a 2 years follow-up of the restoration. The patient is still happy about the result, and I am still proud of my treatment choice, because I really think it is the less invasive one and the most quick and effective one. Now, different patient, same trauma. This girl came to our office some years ago asking for an orthodontic treatment, but probably we were too expensive because I haven't seen her again until she fell off his bicycle, broke 1.2 and 1.1. Well, I'm actually getting thinking that it's not a great idea to ride a bicycle in Gorizia and Trieste if you care about your 1.1 and 1.2. But the curious thing is that when she entered our office, she was quite serene, calm, and with a shy smile, she asked me, "Doctor, since I broke my teeth and I need you to restore them, could you please restore them in a straight way?" I think this request is so naive, isn't it? It's not so simple, but let's see what we can do. Now, what we know from the literature is that every time we need to change the longitudinal axis, we need to change the proximal emergency profile of malaligned teeth. We need to prepare the teeth. We need to open the contact points. We need to prepare the teeth to the lingual surface and just a bit below the gingival margin to go out with a new emergency profile. So I did. I prepared 1.1, 1.2, 1.1, and 2.1. At this point, there are, once again, two paths in front of us that we can work by. We can take an impression and complete the treatment during a second appointment by luting some veneers, or the cheapest one, we can go on with the direct approach. So once again, I use a silicone index to stand the parallel shell. I complete the boxes of the restoration with the sectional matrices. And then once I get the shape box, I start with the labeling phases. This time I decided to go with a simplified labeling technique. I just used one opaque dentin, some stains between the mamelons, and then I cover it all with a body shape medium translucency composite. Why? Because this time I think that in a case like this, color is not as important as it can be the shape for a good result, a good integration of our restoration. So I want to go fast with the layering phases, trying to save some extra time, some extra stamina to take care of the shape, to work on the transition angle, because the complexity is that we have to hide the malalignment of the teeth underneath this restoration. So we can work on the transition angle, we work on the grooves, we also have to work on the texture of the composite. And at the end, I think that we can achieve good result, a good aesthetic result. And I think it's almost amazing what we can do with just two masses of composite and some rubber points. Now, as we have seen, it's not always say that complex situation always required an indirect treatment, as is not always say that the indirect treatment is always the less invasive options. Let's see these guys, for instance. This guy comes to our office after a long orthodontic treatment. He is 23 years old. And he simply needs to improve his smile by closing the diastemas. Now, what are the available treatment options for him? This time, I really think that any no prep, pure additional techniques, no matter if direct veneers, indirect veneers, any technique that simply want to add something onto the buccal surface of these teeth is not a great idea. Why? Because the four upper incisors are already enough pro-inclinated compared to the neighboring teeth, and if we add some more thickness on it, there's the risk that that at the end the patient will smile like one of the Simpsons family, and this can be a big mess. On the other hand, I don't want to drill away any atom of enamel because the patient is still too young, because I cannot presume that whatever I do now will last forever. Probably in 15, 20, 30 years, I will still need some enamel to replace my restoration, to do other type of restoration, I don't know. But I don't want to lose enamel at this stage. So there are only two options left. We can, of course, add some composite in a direct approach to the proximal surface of this teeth, but it's not so simple because it's not so predictable to obtain a good proximal emergency profile by handling some mylar strip or by packing the composite onto a sectional matrices that I am placing, that I am keeping in place with the fingers while we're packing the composite. So I think it's not so predictable. This time I was lazy, so I decided just to take an impression and send it to the lab, asking to the lab to make a number n of porcelain fragments that I'm going to bond onto the proximal surface of the tooth in order to close the diastemas. Where if the first session was a really easy one, the lab phases and the bonding session are extremely stressful because these fragments are so thin, are really difficult to manage, to handle. Any friction may break them in pieces, making you yell long strings of expletives. So it takes a lot of calm, time. You have to be very focused on what you are doing. So as soon as I get the fragments from the lab, the first things that I do is to try them without the rubber dam, just to check and carefully set the proximal contact points. Once done, I place the rubber dam, I place the additional clamps, and then I try again the restoration one diastema per time, because I'm going to bond the restoration one diastema per time. Now, these fragments are made of porcelain, so this means that there is a lot of glass symmetrics in feldspathic porcelain. So we need to etch the entire surface with hydrofluoridic acid 10% for at least 2 minutes before cleaning the surface from the crystalline debris with an ultrasonic bath and the siliconization. We treat the tooth surface, the teeth surfaces, with a total etch adhesive system, and then we start bonding the fragments using a high field flowable composite as luting cement. We start bonding the fragments to close the diastema between the two central incisors. Then we bond the fragments onto the distal part or the distal surface of 2.1, then we move to the canine, we move to the lateral. Once we complete the right side, we move to the left side, bonding the fragments onto 2.3, onto 2.4. In the meantime, I also restored the little chipping of the mesoincisal angle of 2.2 with some direct composite. And once done, once we have finally bond all the restoration in place, well, there is still a lot of work to do, because now we have to remove the incisal stop. We have to work a lot with the rubber points to smooth the over-contouring onto the buccal surface. But in the end, we can see that there is a good integration of this kind of restoration. You can see from the X-rays how precisely do they fit onto the proximal surfaces. We basically have solved the patient problem, because we have closed the diastemas in the patient's smile. Here's a 4 years follow-up. The restoration is still working pretty good. The patient is happy, but the most important thing is that we have solved the problem at negligible biological cost. Now, of course, these techniques, these fragments of partial veneers are only a small part of the indirect universe, where veneers and full crowns are basically the masters, and they are justifiably the main treatment option in highly aesthetic demand cases. As this girl, for instance, who comes to our office. She leaves the credit card at the reception desk and asks for a beautiful smile, whatever it takes. At first, I have to pinch myself because I couldn't quite believe it. But after that, I said, okay, let's take a chair and let's make yourself comfortable. And I start taking some pictures. I start taking some pictures because I want to know where the problem is, what she doesn't like with her teeth. And she immediately said that her teeth were crooked, small, and yellow. So, okay, I got it. And so I can immediately start reshaping, design a new shape for her teeth. Together with my lab, we start waxing up the cast in order to get a silicon index to stamp the direct mock-up, to try to evaluate the aesthetic of our final project. And we want to involve the patient into this evaluation. So we can speak, we can talk with the patient about the aesthetic of our project while she is wearing our final project. She can look at herself at the mirror, she can take some pictures, she can take some video, share it with a boyfriend, with her mom, with whoever she wants. So I really think that the direct mock-up is a crucial step for every aesthetic treatment. But the direct mock-up is also the most effective tool, the most effective guide for a controller reduction of the buccal surface, because we know that porcelain veneers are a very predictable treatment option because their survival rate is around 99% when they are bonded onto food enamel. But it decreases the more denting we expose during our preparation. And unfortunately, the enamel thickness is not limitless on the buccal surface of the upper teeth. We know from the literature that the average enamel thickness is around 1 millimeter at the incisal and median third, but it's only 0.3 millimeters at the cervical part. So we cannot start drilling anything without taking that into consideration. And preparing through the mock-up, using the mock-up as a guide for a controlled reduction of buccal surface really allowed us to be minimal invasive because the burr will work on the tooth surface only where it's strictly necessary. As you can see, on 1.1, which was the most pro-inclinated tooth, we drill away 0.4 millimeters of enamel. But on 2.1, where there's already more than 1 millimeter of space, we simply have to design a margin of our restoration. Once again, we have to change the longitudinal axis. We need to change the proximal profile because of the malalignment of the teeth. So we need to extend our preparation. We need to open the contact point, extend the preparation to the lingual and a bit below the gingival margin so that the lab can go up with a new axis. We take an impression, we send it to the lab and ask for some veneers. We know that there are a lot of materials nowadays with which we can obtain good results with veneers. We can do it with lithium disilicate. Some colleagues obtain very good results also with resin matrix, CAD/CAM blocks, or other materials. But I still believe that feldspathic ceramics is the most aesthetic materials for these kind of cases because it's brightness, because it's translucency, because of the naturalness of the result with that materials. Of course, there is a lot of glassy So once again, I etch the entire surface with hydrofluoridic acid, 10% for at least 2 minutes. Then I clean the entire surface from the crystalline debris with an ultrasonic bath with orthophosphoric acid, and then the silanization. Regarding the tooth surfaces, I sandblast with aluminum dioxide the preparation, then I apply total etch adhesive system. Please take a look at the picture on the right and look how much enamel do we have onto this type of preparation. And once we apply the bonding system, then we start luting these veneers, starting from the 2 central incisor, because I want to be sure that of the position of the 2 central incisor in order to not carrying around mistakes. And then we move to the lateral, we bond the laterals, and then we bond the canine. We refine and polish properly the margin. Here's the situation immediately after the bonding sessions. And here's the final result. I really think that the good result is due to the optical property of the materials, and we can say that the goal is the naturalness of the result. Here's the patient, full smile. She is really happy about about the result, about the new smile, and honestly, so am I. But this is only the start. This is only a small part of what we can of the potential that we have with the adhesive and restorative techniques, because we have seen that now we can really make big changes in the patient's mind, because we can change the position of the teeth, we can change the size, we can change the shape, the colors, always according to the function. But even when the function is lost, we can start thinking outside in. We can start thinking to the aesthetic we want, to be guided in restoring the function we need to get that aesthetic that we want. And in this type of treatment plan, definitely the adhesive techniques and materials are the game changers, because they allow us to work on both the posterior and the anterior teeth at the same time. They allowed us to change the videos, to change the anterior guidance, and creating the ideal condition for a new smile. So let me introduce to you my friend Ivan. His trusted dentist performed a root canal therapy on 1.4 to treat a pulpitis of the tooth. Then he placed a metal post, a temporary crown, and he sent him to me for some veneers. Well, since the moment that Ivan crosses the threshold of my office, it was crystal clear that veneers would have been the last of our problems, at least chronologically speaking. In fact, Ivan is 43 years old with an average oral hygiene, without any TMJ disorder, with a chronic gastritis under investigation, who simply needs to improve his mind. And how to blame him? Now, at first sight, it's obvious that he has lost some videos, that he's that there are tons of decays. But to figure out a treatment plan, we need to go with a deeper investigation. So that's the reason why I start taking some pictures. I take the full set of intra and extraoral pictures. So here you can see the frontal true bite. Here you can see the lateral view. You can see, look at the erosion on this teeth. Here are the occlusal view of both the upper and the lower jaw. And here's a close-up of the 4 quadrants. And then here's plenty of decays. And some of these decays are also very extended. Look at quadrant number 2. And at this point, I cannot be sure that I will be able to keep the vitality of all the teeth. Now, what we know is that tooth wear is a multifactorial condition. In fact, we can see signs of mechanical abrasion, signs of mechanical attrition, but mainly we can see in Ivan's mouth signs of chemical erosion. Now, every time I have a patient with a tooth wear disease, I want to record the tooth wear by using the tooth wear evaluation system, filling a chart in which a chart designed for grading the occlusal incisor and the lingual buccal surfaces. We basically give a score to the tooth wear. We give O when there's no wear, 1 wear within the enamel, 2 wear with exposed dentin, 3 loss of clinical crown height less than 1/3, 3 more than 2/3, and 4 more than 2/3. But the most important thing is that this chart really help us a lot, not only for screening proposal, but also to formulate a treatment plan, because it tells us exactly which teeth are involved by the disease and needs to be restored, but also which surfaces for each teeth. It means that it tells us exactly which type of restoration does every teeth need. If 4.7, for instance, needs just an overlay with a buccal overlap, with a lingual overlap, or a full crown. So at the end, we can say that Ivan has a generalized and moderate wear and a multiple carious lesion. Of course, I take some impression to get the initial static cast. And of course, I propose to increase the length of the upper incisor, consequently to increase also the VDO. So according to these aesthetic requirements, the lab start waxing up only the anterior segment. Then I can try this modification directly in the mouth with a direct mock-up of the anterior segment in order to evaluate the amount of increasing in VDOs that we need. So at this point, we can finally go back to the initial static cast, remount the initial static cast onto a semi-adjustable articulator using an intraoral face bow, a posterior wax, and the lab can finally complete the wax up of the two jaws, of the full upper and lower jaws. From the wax up, I get once again a silicone index with which I can stamp the mock-up directly in the mouth of the patient, because I just want to have an aesthetic evaluation. I just want to check if our project fits into the patient's mind, the patient's face. I want to check the midline, the smile line, and I want to even to be involved into this evaluation. So only once both of us are happy about the aesthetic result that we have projected on the lab, I am finally able to tell Eva something about his treatment plans, because now I know where the starting point is. Now I know what I want to reach, and so I can derive all the steps of my treatment plan. Treatment plan that considers three fundamentals moments. The first phase is the control phase, in which I'm going to remove all the inflammatory process, all the infection from Ivan's mouth. So I'm going to pull out the non-restorable teeth. I'm going to do some periodontal therapy. And then I'm going to treat the carious lesion with some direct restoration at the initial VDOs of the patient that will work as a build-up for the final phases. Only when the entire mouth will be back to earth, we can move to the second phase of the treatment, in which we are going to test the function of our project with resin bond and splint. And after a couple of months, if no TMJ disorder, pain, or other issues will happen, we can finally proceed with the final phases, in which we are going to transform the tested shape with the bonded resin splints into final restoration by a segmental preparation with separated splint. Now, I take my time to explain carefully all these steps to Ivan, and only when I'm sure that Ivan has fully understood all the steps, once he has signed the quotation, okay, I can move on with the control phase. So I pull out the wisdom teeth, I do some periodontal therapy, and then I start treating the carious lesion. So 1, 2 teeth per session. I start opening the cavity, cleaning the cavity. I apply the adhesive system, and then I start directly restore these teeth at the initial videos of Ivan. My goal is to remove all the decayed and softened dentin and to seal all the exposed dentin. So we start with the two upper incisors, then we move to the lateral, to the lateral, to the canine, then to the premolars. Here you can see that on 2.4 and 2.5 was a big mess, because the erosion and the decay was all around the tooth, so it was quite a bit complicated to manage this situation with the matrices. But we have some patience and some calm. I deal with it. We move to the molars, then we move to the lower jaw and we do always the same thing, a couple of teeth per session. At the end, finally, have complete the first phase, and we have back the oral health into the patient's mouth. Only now we can start thinking to reshape the teeth, and now we are ready to proceed with the second phase of our treatment. So we apply some adhesive procedure onto the tooth, onto the teeth, and then we stamp the two direct mock-up on the upper and the lower jaw. This time I want to polish and refine very carefully the margin and the surfaces of the two mock-up in order to get them more cleanable, more flossable, and more sustainable, because the patient have to wear them for at least a couple of months. And then I say, see you soon to Ivan. And after a couple of months, Ivan comes back to our office. He is happy about the aesthetic result, quite comfortable with the new DVO, no TMJ disorder, pain, or other issues has occurred. And so we can finally move to the final step of our treatment. And once again, we use the mock-up as a control guide for the occlusal reduction. So we prepare through the mock-up in order to get a controlled reduction of the occlusal space, to get the necessary the necessary space for the minimum thickness of the restoration materials. And I research the margin of the initial cavities, the margin that were determined by the carious lesion and the erosion, because there I want to place also the margin of my final restoration. Then I transfer the tested bite with a reciprocal transfer method. I send the impression to the lab, and I get back different types of restoration. For example, I have an overlay onto 4.7, an overlay with the buccal overlap onto 4.6, 4.6, 4.5, and the head. So during the second appointment, we start the luting phases. So we isolate all the field, I sandblast the preparation. Then once again, I apply the adhesive system. I treat the entire surface of the restoration. And then we have a high field flow of the composite. One by one, I proceed in luting all this restoration. Once the fourth quadrant is completed, I finish and polish the margin, and then I move to the third quadrant, and I do the same things. I isolate all the field, I sandblast the preparation, I apply the adhesive system, I treat the entire surface, and once again, using high field flow of composite, I lute all of this restoration one by one. I refine and polish the margin, and at this point, to complete the restoration of the lower jaw, we need also to restore the canine, to restore the anterior guidance. This time I decide to go with a direct approach, so I get a silicone index to stamp the new height of the canine, and then freehand with some composite, I do just some direct veneering onto 3.3 and 4.3. I finish and polish properly the composite surface. This is how they look like at the end of the polish procedures. And now that we have completed the treatment of the lower jaw, we move to the upper jaw, and we do the same things. So once again, we prepare through the mock-up to get a controlled reduction of the occlusal space. We research the initial margin, the initial cavity margins, because there I want to place also the margin of the final restoration. I take the impressions, and once again, I get from the lab different types of lithium disilicate restoration. I get some overlay with overlap, buccal overlap, lingual overlap, or some full crowns. During the second appointment, I lute this restoration, so I start luting 2.7, then the overlay with the buccal lingual overlap on 2.6, the two full crowns on 2.4 and 2.4, then the quadrant number 1, once again, overlay for 1.7, overlay with a lingual overlap for 1.6, overlay with the buccal overlap for 1.5, and a zirconia full crown on 1.4 because of the metal post. Now, once that we finally have a good and stable posterior support at the increased and the new videos, well, the worst is finally over, because now we just have to focus on the anterior of the upper anteriors, and we approach them as we usually do for the veneers. So we prepare through the mock-up for, once again, a controlled reduction of the buccal surfaces. The lingual surfaces are already chemically and mechanically self-prepared by the patient, so that we simply have to connect the buccal finishing line with the lingual finishing line through the contact points, and ending with a preparation like full crowns or full veneers or 360 degrees, as you prefer. We take an impression, and we ask to the lab to get 6 full veneers, micro-layered lithium disilicate full veneers. We know from the literature that this solution, when these full veneers are bonded with the proper adhesive procedure onto the tooth surface, is a very predictable treatment. The survival rate is around 99% at 8 years, with only 12.5% of repairable complications. So definitely is a predictable treatment option. And so we did. The lab gave us the restoration. We tried them with a rubber dam, and once I'm completely sure about the result, I finally complete the treatment by luting them with the right adhesive procedure. So I put all the teeth, all the preparations under the rubber dam. I sandblast the preparation. I start bonding the 2 central incisors together. Then we move to the lateral, to the canine. I refine and polish properly the margin. Here's immediately the result after the bonding session. Here's a couple of weeks later, in which you can see the final aesthetic result. Here's the occlusal view of the anterior restoration. Here's the 2 jaws fully restored into the aesthetic. The function of the 2 upper and lower jaw fully restored. And yes, we can definitely say that the final result showed a satisfactory result for both aesthetic, functional, and biological integration of the full mouth rehabilitation. Definitely the mouth of Ivan is completely changed, and the most beautiful and important thing is that all teeth are vital. We have been able to keep the vitality of all the teeth. So here's the final even final smile. And I think that we can say that this is the great potential of the adhesive materials and techniques nowadays. Nowadays, as we have seen, there are a lot of solution techniques, materials to make several stuffs. But there are no miracle materials or technique that can solve all our problems. We need to assess the situation and choose the more suitable approach for that specific clinical situation, the more suitable approach to simplify our daily work. And even when it seems complicated, we can always, even when it seems complicated, all the problems can be unpacked into separate, more affordable problems that we can face one by one. And last but not least, we should always remember that to be predictable in our daily practice, the key for being predictable are not the tips and the tricks, but is the application of codified protocols in our daily work. So I hope I am on time, and I want to thank all of you for the attention, and I'm available for all your questions. I will leave you once again all my contact.